I'd like to introduce Dr. Nazeerah Varachia. She is currently a ComServe doing obstetrics and gynecology. And she was in the emergency department in emergency medicine in the first half of the year. She did a really cool talk, but then was preparing for her exams, her HIV management diploma. And she did promise us that she would try a Zoom talk for us after her exams. So yeah, exams are done. And thank you very much, Nazeerah, for doing the talk. Please can I remind everybody that does join us to please keep yourselves muted, and we'll save questions and comments until the end. You can also put questions and comments into the chat, and I will read them out at the end.
Sure. Okay. Thank you so much. An approach to bradycardia in children. So basically what we'll be going through is a definition, basic anatomy and physiology, classification, recognizing bradycardia, and managing bradycardia. So what is bradycardia? So bradycardia is defined by a heart rate that is less than the lower limit of normal for age, activity level, and clinical conditions. So basically from 0 to 3 years, it's less than 100. From 3 to 9 years, less than 60, and from 9 to 16 years, less than 50. So as you know, the electrical impulses spread. So when there's a sinus node dysfunction, there's disordered automaticity or impaired conduction of the pulse from the sinus node into the surrounding arterial tissue. And the AV node sends electrical impulses from the bundle branches throughout the left and right ventricles. So if there's an AV conduction disturbances, that may result from impaired conduction in the AV node or below it, such as the bundle of hairs. So how do we classify bradycardia? So we can divide them into primary causes and secondary causes. So our primary causes include congenital abnormalities of the heart pacemaker or conduction system, cardiomyopathies, myocarditis, or surgical injury to the conduction system or to the pacemaker. Our secondary causes include our hypoxia, hydrogen ions, which is acidosis, hyperkalemia, hypothermia, heart block, and toxins, poisons, or drugs. So an important concept to note is cardiopulmonary compromise. So as you can see here, cardiac output, which is the volume of blood pumped by the heart per minute, is a product of stroke volume, which is the volume of blood pumped with each ventricular contraction and the heart rate. So the heart's ability to increase stroke volume is very limited during infancy and early childhood. So cardiac output declines with bradycardia and can therefore lead to cardiopulmonary compromise. So what are your signs of cardiopulmonary compromise? So that includes hypotension, altered mental status, shock, respiratory distress, chest pain, or vague feeling of discomfort, or sudden collapse. So on this slide, we can see a sinus bradycardia. So that's a sinus node depolarization that is slower than normal for the child's age. For this diagnosis, a 12-lead ECG must be normal with normal P waves, but with the rate below normal for age. So this can present in healthy children or athletes, or can develop in response to hypoxia, hypotension, and acidosis. Drug effects may also result in a sinus brady. So always important to evaluate the clinical status of the child when assessing a sinus bradycardia. On this rhythm strip here, I don't know if anyone wants to give it a go, you're most welcome to. So as we can see here, there is a prolonged PR interval. However, all atrial impulses are conducted to the ventricle. So we would identify this as a first-degree AV block. On this rhythm strip here, so we can see that the PR interval is progressively lengthening until a P wave is not conducted. So we would classify this as a second-degree AV block as a Morbitz type 1. And the rhythm strip below that, we can see that the PR intervals remains constant, but some P waves don't conduct. So this would be classified as a second-degree AV block, a Morbitz type 2. And this rhythm strip, we can see that this is a third-degree block or a complete block, as there's no association between the atrial and the ventricular activity. So basically, this is just a summary of all the blocks. So let's discuss managing peds bradycardia. So this is the algorithm which we'll go through. So step 1, does the patient have bradycardia? So if the patient presents with bradycardia, you want to assess for cardiopulmonary compromise. So does this child present with hypotension, an acute mental status, or any signs of shock? So if the answer is yes, we'll go on to assessment and support. So basically, you need to maintain a patent airway, assist breathing and positive pressure ventilation and oxygen as necessary, and use a cardiac monitor to identify rhythm, monitor the pulse oximetry and blood pressure. So if there are no signs of cardiovascular compromise, then support your ABCs as needed, consider your oxygen, observe and perform frequent reassessments, obtain a 12-lead ECG, and identify and treat any underlying causes. So if the heart rate is less than 60, then you'll start your CPR despite oxygenation and ventilation. And then you need to determine, is this bradycardia still persisting? So if pulses, perfusion, and respirations are adequate, no emergency treatment is needed. However, monitor and continue evaluating. So if the bradycardia and cardiopulmonary compromise persist, continue your CPR, get your IV or IO access, administer your atropine for your increased vagal tone or primary AV blocks, consider transthoracic or transvenous spacing, and identify and treat any underlying causes. Always check your pulse every 2 minutes. If no pulse is present, then go to your pediatric cardiac arrest algorithm. If your pulse is present, reassess to see if the bradycardia and cardiopulmonary compromise continue despite oxygenation, ventilation, and CPR. So if your bradycardia and cardiopulmonary compromise have improved, support your ABCs as needed, consider oxygen, observe and perform frequent reassessments, obtain your 12-lead ECG, and identify and treat any underlying causes. So medications that we can use is adrenaline. So this is for symptomatic bradycardia that persists despite effective oxygenation and ventilation. So this has stimulatory effects on the alpha and beta adrenergic receptors. So the beta adrenergic activity increases the heart rate and contractility, and the alpha adrenergic activity causes vasoconstriction. So how do we mix this up? So you'll take 1 ml of 1:1,000 amp of adrenaline, and you'll dilute it in 9 ml of water for injection.
This gives us a 1 in 10,000 solution of adrenaline. The dose of adrenaline for bradycardia is the same dose as the adrenaline for cardiac arrest, which is 0.01 milligram per kg of adrenaline, which is the same as 10 micrograms per kg, or 0.1 mil per kg of a 1 in 10,000 solution. Why do we have to do it like this in South Africa? Well, it's because we don't have the pre-diluted amps like they have overseas. So this is the reason why we need to dilute our amps, and then it makes it much easier. 0.1 mil per kg of a 1 in 10,000 solution of adrenaline then can be given intravenously or IO. This dose can be repeated every 3 to 5 minutes as required. Our time interval is usually every 4 minutes.
The other medication that we can use is atropine. So atropine competes with acetylcholine for cholinergic receptor sites on the SA and the AB nodes. By blocking acetylcholine, atropine speeds up the heart rate, and at specific doses, it also prohibits vagal cardiac slowing or asystole. So how do we give this? So for IV or IO access, you can give 0.02 milligrams per kilo with a minimum of 0.1 milligrams and a maximum of 0.5 milligrams. So what are the contraindications for atropine? Does anyone want to give it a go? So it's basically your 3 H's, which is your hypothermia, hypoxia, and head injury. So another thing that we can consider is cutaneous spacing or temporary transvenous spacing may be life-saving in certain cases of bradycardia caused by a complete heart block or any abnormal sinus function. So it's always important to remember to treat your reversible causes. So for your hypoxia, you'll give your oxygen and ventilation as necessary. For your hyperkalemia, you want to stabilize the myocardium and shift it intracellularly. For drugs, toxins, or poisons, you want to treat it with a specific antidote and provide supportive care. For any trauma, if there's a head trauma, elevated intracranial pressure can cause bradycardia. Provide your oxygen and ventilation. For hypothermia, you want to warm the child as necessary, but also avoid any hyperthermia if the child has a cardiac arrest. And for heart block, you want to consider the use of atropine, chronotropic drugs, and pacing. Always remember to keep calm and call for help. So print out your initial rhythm strip and also print out your 12 leads ECG. It's example history. So you want to go through the signs and symptoms. Does this child present with chest pain, confusion, fainting, fatigue, dizziness, etc., and the duration of the symptom? Do they have any allergies, medication of any family members, such as your beta blockers, calcium channel blockers, etc.? You want to know their past medical history. Do they have any diseases such as hypothyroidism, congenital heart defects, etc.? Any past surgical history, such as any complications of heart surgery, any travel history, such as malaria, etc.? When was the last meal or medication, and the events leading to the presentation. So for your secondary survey, you want to do a full head-to-toe examination. So reassess your vitals, what is your heart rate, your sats, your blood pressure, etc. And then do a full general examination and a systematic examination. So you want to see, is there any peripheral and central cyanosis? Is there clubbing on the head and the face? How are the pupils? Are they dilated? Are they constricted? Are they unequal? Are there any signs of head injury on a nose or mouth? You want to see for any signs of obstruction, mucosal edema, any evidence of ingestion of toxic substances. With your RASP examination, you want to see the effort, the air entry. Are they having difficulty breathing? On your CVS examination, you want to auscultate the cardiac region. You want to palpate the peripheral pulses. You want to check the capillary refill. On the abdomen, is there distension or hepatomegaly? And on your extremities, are there clubbing, cyanosis, edema, or any signs of trauma? So you want to find them, you want to flag them, you want to fix them, and then follow up on it. So this is an ongoing reassessment. So it's essential to evaluate the response to treatment. It helps to track your progression of identified physiologic and anatomic problems, and you may identify new problems on reassessment, which will guide you on your ongoing treatment. Thank you so much.